I think Dr. Moore just set this up perfectly. The core of the work at the network is centering the patient. Their lived experience, expressed in their own words, are a key component of our research initiatives. Our last, but certainly not least speaker, Dr. Dee Gardner, will share some of the many allergy asthma network studies that focus on the voice of patients and caregivers as it relates to oral corticosteroid use and biologics. Dr. Gardner is the Chief Research Officer at Allergy Asthma Network. She leads the research mission and oversees the Trusted Messenger Virtual Asthma Coaching Program. Dr. Gardner is responsible for leading the survey research programs and coordinates partnerships with other nonprofit organizations, academicians, pharmaceutical companies, startups, and community organizations with patients, ensuring that the patient voice is at the forefront of the AAN research mission. Come on up, Dee.
Thank you all for sticking through the rest of the day. We will keep moving forward. I appreciate you guys being here. So we took some time to talk to parents and see what their thoughts were of oral corticosteroids and biologics. This was a survey that was sponsored by the Sanofi and Regeneron. So we're going to walk through a little bit of the results and then we'll be done. So parents were identified through an online database through a company called Dynata, and that company identified people who had children that were between the ages of 6 and 17 that had had an exacerbation in the last 12 months. And so we were wanting to understand, what do parents think of oral steroids? What do they also think about biologics? Do they think they're safe? Do they think they're not safe? Where do they want to see them in the future, and would they use them in the future? So we've just heard all about research, and so the population that participated was predominantly white, which is not unheard of, right, in regards to the research that we do, and also predominantly non-Hispanic. They were between the ages of 30 and 39, and most of them had some type of college education, and then were $60,000 to $99,000 on an annual income. But when we looked at the children actually, 66% of them had an exacerbation in the last 6 months. And so when we think about asthma, where do people seek care? I'm sure this won't be a surprise. Do they look at the doctor's office? Do they go to the urgent care? Do they go to the hospital? Is there one that someone would go to more frequently than the other?
Okay, we have 20% said urgent care and 80% said hospital ER. Okay,
so that might be surprising to you, but on the survey, what we found is that most people went to the doctor's office. I hear some people say BAM, good. So most people went to the doctor's office. We did have 500 people answer the survey, so that's 500 parents, which is quite remarkable to have that number of people participate in a survey that's online. Some people went to the urgent care, and then a smaller percentage, as you can see here, went to urgent care, and then a little bit of a larger percentage went to the hospital emergency room. We asked questions dealing with the rules of two, and if you're not familiar with the rules of two, the 3 questions that are listed here are basically those. Does your child use their reliever inhaler more than twice in a week with asthma symptoms? Most people said yes. Does your child wake up at night because of their asthma symptoms more than 2 times a month? The parents said yes. And then does your child refill their quick relief medication more than twice in a year? And they said yes. So out of the people who completed the survey, we found that majority of them, this again probably is not surprising to you, but 92% of the parents said that their children had uncontrolled asthma based on the rules of two. So how many times does a child get treated for asthma in the last 12 months? Our study showed that they saw someone or had an exacerbation, in about an average of 3.5 times. But it seems like most parents reported that their children had an asthma exacerbation twice in a year, so every 6 months or so. Then the medications that were prescribed, most people were prescribed an albuterol inhaler or nebulizer. But the thing to look at here, again, I don't have a pointer, but the piece that we're really interested in here is the percentage of patients that received an oral steroid, whether that be a pill or the syrup type of oral steroids. That was like 36% or so that received those. When we think about has your child missed asthma, has your asthma missed, the coloring of that is really bad. It caught me off. Has your child missed school because of their asthma in the last 12 months? And again, this is not surprising, but majority of people say yes, of course. Again, we saw that 92% of the children had uncontrolled asthma. Majority of them are missing school. So then we're very concerned. So then we think about the perceptions of oral steroids. We ask parents specific questions about oral steroids on what they thought the safety was of oral steroids on a scale of 1 to 10, 1 being not safe, 10 being very safe. And we see here that there's an average score of about a 7.2. But if you look at the number 7 to 10, majority of people believe that oral steroids are safe for their child to take. So when we look at agreement in regards to safety and also in regards to why a child would take oral steroids, you can see here that when a parent reads the statement, I believe that my child with asthma will be sick longer if they don't take oral steroids, then we start to wonder what is happening, because if a parent believes that their child has to have oral steroids to get better with an asthma exacerbation, then that's what they're going to expect in the long run. And then when you see here, when I visit a healthcare provider for my child's asthma, again, I expect that prescription. So majority of parents see that their child gets better, and then they expect that prescription. But is that really the answer that we're wanting to see? Because we know that oral steroids have a long-term and short-term side effects. So again, here we're looking at the average number of times in a year that a child is receiving oral steroids, and that's 3 times that a kid is receiving oral steroids. So 3 times in 1 year, one kiddo getting that. And if we say that a kid is having an asthma exacerbation at least 1 time in the last 12 months, and we think about kiddos between the ages of 6 and 17, how many rounds of oral steroids are they receiving? That's a long time to be taking oral steroids. So we then asked the parents, we gave them a definition of what short-term outcomes, short-term side effects are, rather that be mood swings, something that happens within a short time of taking the medication. And then we also gave them a definition of what long-term side effects are, which are, a long time, over a lifetime of you taking these medicines. And we gave them some different identifiers of what those would be or could be. And you can see here that parents believe, again, that they believe that the short-term side effects, that they are familiar with those, but we do see that they're not as familiar with the long-term side effects. So when we look here with the oral steroids and on the side effects, we asked the parents to identify the 2, they had to rank the 2 different types of side effects they were concerned about for short-term. So most parents were concerned about the mental disparities. So parents were concerned about anxiety, and they were concerned about the mood swings that their child was experiencing when they took oral steroids. When we asked them to rank the different side effects in regards to long-term side effects associated with taking oral steroids, we can see here that parents were concerned. And again, these are the only choices that they had. We'll talk about one of the concerns. So cardiovascular disease, depression and anxiety, and sleep apnea. Those were the 3 that were listed in the survey. So when we think about healthcare providers, believes, or the parents believe, that their healthcare provider has informed them of the cumulative effects of what goes on with their steroids. And here you can see again, majority of people agree or strongly agree, very few disagree. So in regards to oral steroids, we recognize that with children, that long-term side effects include what we listed, but also what was missing is that adrenal insufficiency and growth are a concern for parents. So we recognize that those 2 factors are missing from the survey. So when we think about perceptions of biologics, again, we're asking parents after a period of time, You've learned about, or we're asking you questions about short-term, long-term side effects of oral steroids, and then now we're wanting to understand their perception of safety and what biologics do. So when we ask them in regards to agreement, in regards to biologics decreasing the frequency of asthma exacerbations or asthma flares, majority of parents say, yes, we do agree that if my child was on a biologic, their asthma exacerbations would decrease. We also agree that if our child was on a biologic, that they would be able to participate in sports or activities, whichever you would like. They also would be able to, they would be safe, but the thing with being safe is, again, I don't have a pointer here, is that you do have parents that are a little bit unsure. The 42% are unsure if that is actually true. And I think that Dr. Mora also made mention of this and some other presenters about biologics, parents' perceptions of using them. And then biologics decrease the need for oral steroids. Parents, again, here you can see the percentages that majority of them are kind of still on the unsure side. So when we think about biologics being prescribed in the last 12 months, we asked all parents. You can see that 74% said no. Why? If their child is having numerous exacerbations, they're not responding to medications, then what's the answer? So we have some gaps to fill. The people who were prescribed biologics, as you can see here, is that majority of them, the percentages that are seen are majority of people made greater than $60,000 a year. We see that people who identified as being Black were prescribed biologics. Those that had children between the ages of 6 and 11, obviously the ones that missed school, and the ones that had uncontrolled asthma. That was with the ones that were 130 people that said that yes, their child was prescribed a biologic. So which biologic is the most common? The one that you see at the top, Dupilumab, is actually the one that is most common. And then when we look at out-of-pocket cost, and I think this is what speaks to many people, is that out-of-pocket cost is a concern. So we can see here that the monthly out-of-pocket cost for biologics on an average was about $1,300 for people who had private insurance. And then if you look all the way to the left or your right, children covered by Medicaid, the cost was about $1,100 a month. Then when we think about benefits, when we talk to parents about benefits, then we listed a number and then they could choose the ones that they felt were the most important. You can see that most people felt that, again, with biologics, that their kids would have fewer asthma exacerbations and that they would use their quick relief medication less. But then when we talked about the drawbacks, why wouldn't you have your child take a biologic? Then you can see the answers there, is that they're too expensive, out-of-pocket cost, and that the child is fearful of needles. So, and then the next one below that is too much time in a doctor's office. So we just heard about research, right? Is that when we think about the gaps in research and we want people to utilize medications that we're wanting to prescribe for them, we have to make things user-friendly. We have to meet them where they're at, and we have had the same theme throughout the afternoon or throughout the day. And so, again, trying to educate, there's lots of gaps that we can fill here. So parents of children actually perceive OCS as being safe, but they also expect to receive those when they're having an exacerbation. And I think that that could be an opportunity for education, rather that be an education campaign, rather that be education in the clinician's office, but we need to provide education to our parents to ensure that their kiddo and them know how to manage their asthma. So asthma education is extremely valuable in the long run. If the family doesn't know how to manage them, they don't have the indoor air quality checks to ensure that they can get rid of whatever needs to get rid of, whatever the child's allergic to, assuring that that asthma education is taking place. And we've heard a number of great stories today, and also hearing from the different, from the Boston campaign that was here. So parents weren't familiar with the long-term side effects of oral steroids, and I think that's also a conversation that needs to happen. Again, it may not be something that happens in the office every day, but if you are a practitioner and seeing that kiddos are taking oral steroids numerous times over the years, and you're the one taking care of the family for 5, 6, 7, 8 years, and we're seeing all of this taking place, that we need to try to maybe figure out a different way to hopefully educate and decrease the number of oral steroids that the kiddo is receiving. And then also parents parents agree that biologics do have a benefit. So we're not here saying that biologics are the answer to everything. It is an answer to some children that have asthma that is not reacting to the medications that are being prescribed. The average monthly cost is costly, but we do recognize that there are assistance programs for parents to utilize biologics if they're prescribed and they want to go in that direction. Parents say that they don't know that these assistance programs exist, and they also don't understand the process to go through from day of prescription to day of receiving. So we need to make sure that the whole wraparound service is provided to those parents. So I thank you for your time. I'll turn it back over.
And thank you, Dee Dee. It's always important, as we've talked about at length today, to center from where the patients are coming from their perspective, what they're seeing, what they're thinking, so that we can see that gap, that gulf, actually, between some of the research and some of the treatment protocols, and wonder why what's happening at home is happening. Any questions for Dr. Gardner?
Yes, Wanda.
I was being quiet before.
No, you can't. Don't be quiet.
One factor that this is personal, that sometimes the physicians or the healthcare providers will get tired of, these visits, and also because the patients know that the oral steroids, they work, and they want it, everybody wants to get healed fast.
Right.
Now, yesterday.
Yes.
And so I had the experience of having a standing PRN order for OCS. And that was like 10 years ago. But then a couple of years ago, I was talking to some of the doctors, and they were still doing the same.
Yes.
So I think it's, very important. Yes, we're educating the families and the patients, all the stuff, but the healthcare providers, they need to stop and think, what are the consequences of having these PRN standing orders?
No, I appreciate your comment, and I'm not a prescriber, but we have many of them in the room, and I do believe that many of our patients, when they seek care within their specialist, sometimes it may be that specialist has a different priority in regards to OCS versus when they're going to the urgent care, the emergent care, or a PCP, and I'm not dissing any PCP by any means. It's just, again, we have a number of our patients who have asthma that truly are not seeing a specialist. And so that's a gap too, right? Is that you're going for asthma care all the time not all the time, but a lot of the time to an urgent care center. And so that urgent care center is treating based on what they're seeing at this moment in time. And so they're going to this urgent care, then that urgent care, then this urgent care, whatever's available based on insurance or no insurance. And so what they're receiving is what they're getting. And again, they have this gap on getting to a specialist. And we've seen research that shows that getting into an allergist or a pulmonologist is 6 months to 18 months. So patients they're stuck. They're stuck. And so having these orders, as you have reflected on having a PRN or as needed steroid, sometimes is kind of the fix for the moment, but it doesn't fix the long run. And the long run is being presented right now, actually at the college meeting at 3 p.m. at Monitor 22, go over there, see the research. But yes, we have two presentations speaking specifically to what you're talking about too, is that we're trying to make sure that that we recognize the gap, that us as practitioners, that our communities at large are all singing the same song and trying to help patients get where they need to go. Absolutely. Question?
I just want to add to the question from my friend right there.
Wanda, yes?
Yes, that gap that you're mentioning, it maybe could be covered by the asthma coordinators, which is I'm one of them.
Yeah.
And then we were discussing also one of the providers here that, yes, they only have like 15 minutes
Right.
to see one one
Correct.
patient. But that's what we come into.
Correct.
And that's what we do, the connection. I've been done this for 25 years.
Yes.
And the connection with my patients, that's the best part, that the patients can actually follow the instructions from the doctor. Because when they say, oh, the doctor did not tell me that, and I say, well, that's the reason you're here with me.
Yes.
Because I have the time for you, and I'm here for you.
Yep.
So when we do that connection, and even at this point, with the new, well, it's not new guidelines, because the GINA has been there for a while, but we haven't implemented like global, like the name it is.
Yes.
I've been training with respect with the pharmacist.
Yeah.
I have to call the pharmacist, and I have to train the pharmacist and telling them what is the new guidelines with smart therapy.
Right.
Because they're not familiar with it, and they're not processing the prescription from a provider because they're not familiar that now that medication can be used as needed as well.
Right.
So, and then I also connect with the schools.
Yep.
So it's like a connection with the whole, around the patient. It's not just the provider.
Right.
And that time that I spend with my patient, it will make a huge, huge difference, because I even requested to have my cell phone to be connected with my patients. So they can call me anytime. And they say, oh, this medication is not covered. I have a problem with the pharmacy. I call the pharmacy, and that's like the gap in there, the education part. And I'm agree with Ms. White, right? The passion, the education, the motivation that we have to help one patient, and not looking at, I think we're connecting everything that everybody's talking right now, because we're not looking who is coming, who the person is. For me, every patient comes, it's like part of my family.
Right.
And I treat them that way. And when I do that, then we get very good outcomes from that patient. They come into their follow-up visits, and then we are able to get resources for them with the other needs, because that's another part.
Yeah, absolutely.
For them, it's not just asthma. It's like more things that we need to be prepared for it for them and give resources to them. So they will feel like, oh, I have a way here that I can get help. And then they respond differently.
Yeah, absolutely. And so that ties us into our Trusted Messengers virtual asthma coaching program. AAN, you spoke about ALA, but the Allergy Asthma Network does have a virtual asthma coaching program that Leandra and Ruthie are a part of, and we have a few other of our asthma coaches here. But we provide one-on-one asthma care for about 45 minutes to an hour for 6 weeks in a row, going through exactly what you're talking about, is trying to fill the gap, because we recognize that healthcare providers they do want to do that. They're in healthcare for a reason. They're there for their heart, right? And so trying to make sure that their patients have the opportunity to have education is important. And so again, if the healthcare providers are short on time, asthma educators are really the answer to that, rather that be you being an asthma educator, a respiratory therapist, or the virtual asthma coaching program, or other programs across the country. We all need to be able to help our patients. But we need to know we need to know where the physicians or the healthcare providers, who they are and who needs help. And that's one of those voids that I think sometimes is in existence, because we don't know. You have a great setup because you are connected. We need more of those types of connections so that we can help our communities get to better health care. As Ruthie had said earlier, the goal is better health care in the long run, so that we can reduce these deaths that we've been hearing about this morning, and having people have very poor outcomes. So I appreciate your comments about the importance of education, because I too am all about patient education, 100%. Yes.
So I'm just curious to know, why did you do more Caucasian women with higher income levels as opposed to what was you trying to find out?
So
is it
the
bio?
Yeah.
Was that it?
No. So with the surveys, when we send them out through the system that we send it out through is a company called Dynata. Dynata has online survey takers, and that's the company that provided us with the data. We gave them the survey, they put the survey into their online database, They have people who sign up to be a online survey taker, and they identify themselves as being a parent of, and they qualify and quantify these people to participate. We don't choose who answers the survey. All we do is open the survey from one day to the next, or the one day to the end. And when we are looking at the data, it's whoever answered the survey between that time. If we were truly, looking at it going forward, if we were truly looking at specific groups of people, we could go back and ask for us to redo the survey and go to different communities and do that hand by hand. But right now, this is an online survey that was answered. And so that's why you see the people who answered the survey.
More for middle class.
Well, it was for whoever was part of the DINATA survey taking panel is what it was, yeah. So we didn't go to anybody's community to ask them to take the survey. It was online.
Okay, thank you.
Uh-huh.
Thank you, Dee Dee.
Thanks.
Excellent. And another clap for Dee Dee, who's a respiratory here. So she is a tremendous provider, researcher, and all of those things. So thank you, Dee Dee. We're here. What a wonderful, insightful, and informative day.